Hello everybody, my name is Mitchell Farmer and this is part 2 of Laboratory 4 dealing with the abdominal cavity and the GI tract. The first thing I want to start us on today is the pancreas. So pancreatic anatomy as it's taught in the dissector fortunately is relatively simple. This is going to be a rather quick video, but let's get started. So the first thing I want to discuss is the head and the uncinate process of the pancreas. So the head of the pancreas, highlighted here, at least within my model, also incorporates the uncinate process. Uncinate means hook in Latin. So essentially, what the uncinate process is a hooked area just inferior and continuous with the head of the pancreas. So if I draw it out here, you can see it right here, and it would hook around like this. This rest of this is the head of the pancreas, and this uncinate process is continuous with the head of the pancreas. Some things of note in regards to the head of the pancreas is that the common bile duct travels through the head of the pancreas. And so say if you had a pancreatic tumor or something like that, you could get obstruction of the common bile duct as it travels through the head. As far as the blood supply of the pancreas goes, you have the superior and inferior pancreatico-duodenal arteries. So essentially you have the celiac trunk. I'm just going to get this out of the way. The common hepatic, which gives off the gastroduodenal. The gastroduodenal gives off the superior pancreatico-duodenal artery, of which there is a anterior and posterior branch. So just to repeat that, there is an inferior pancreatico-duodenal and there is a superior pancreatico-duodenal, both with an anterior and posterior branch. Here's the anterior branch of the superior pancreatico-duodenal, and if we rotate the model posteriorly, here is the posterior branch. This anastomoses with the posterior branch of the inferior pancreatico-duodenal. And if I zoom out and we rotate back anteriorly, we can see that anastomosis takes place right here. And this is the anterior branch of the inferior pancreatico-duodenal, which is highlighted here, and it is a branch of the superior mesenteric. So it's relatively simple. There's only two arteries of interest. Both have an anterior and posterior branch. Their anterior branches anastomose, and their posterior branches anastomose. So moving on from the head of the pancreas, there is something known as the neck of the pancreas. It's not shown in this model, but essentially you can see where approximately would be the head and the body would be attached by the neck. In the cadaveric dissection and in a more anatomically accurate model, the neck lies anterior to the superior mesenteric vessels. I only have the superior mesenteric artery here, but it also lies anterior to the superior mesenteric vein. So you can imagine the neck is approximately right here, despite on the model this shows this all to be body. Now moving on to the body lies posterior to the lesser sac, which I've talked about in a previous video. And the body also has the transverse mesocolon attached along its inferior margin right here. And if you recall, the transverse mesocolon is a mesentery that suspends the transverse colon. Finally, there is the tail of the pancreas. The tail of the pancreas passes through the liano-renal ligament, a ligament extending from the spleen to the left kidney. If I just throw that in really quick. So there's a ligament that extends from the spleen to the left kidney, and that encompasses also the tail, as well as the hilum of the spleen, which is the entrance point of the splenic vessels. So that's pretty much everything I wanted to talk about relative to the pancreas. Let's move on to my next constructed model, the intestines. So we have an anterior view here, liver, large intestine, small intestine. I only have the ileum here, not the jejunum or the duodenum, but we don't really need it for our purposes. So I guess starting with the large intestine, there's just a couple things they want you to note how to differentiate the large and small intestine, so I'm going to go over those really quick. Essentially, the large intestine is significantly smaller, about 1.5 meters in length, as you can see. And it's immediately apparent that the small intestine is much more convoluted and then so likely larger. The large intestine also contains something known as Tinea coli, which I've highlighted here. It's essentially 3 bands of longitudinal ribbons of smooth muscle that contract lengthwise to produce Hofstra. And Hofstra are these outer saculations that are present. You can kind of see them here, 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 and here. And those are produced by the contractions, longitudinal contractions of the Tinea coli highlighted here. Other things that help you distinguish large and small intestine is something known as appendices epicloacae, which aren't present in this model but are essentially fatty tags off the large intestine, but you'll be able to see them in the cadaveric dissection for sure. Also, the small intestine is suspended entirely from mesentery, whereas the large intestine, only the transverse colon and the sigmoid colon are suspended from mesenteries. The descending colon and ascending colon are retroperitoneal, whereas the small intestine is entirely intraperitoneal. Speaking of the small intestine, some of its defining features are that it's much longer, ranging from anywhere from 6 to 7 meters. However, it's smaller in caliber, or I guess you could say diameter. It's more mobile than the large intestine because it is intraperitoneal and suspended from an extensive mesentery known as the mesentery of the small intestine. Very inventive name there. Also, it has smooth outer walls without those Hofstral saculations that we see here, and it lacks the Tinea coli. And that's kind of just a really quick tutorial of how you distinguish those two types of intestine. The next thing to discuss is the cecum and appendix. So the cecum is essentially a sac at the end of, or I guess the start of the ascending colon, where the ileum joins the large intestine, or the small intestine joins the large intestine at the ileocecal valve, which unfortunately isn't present in this model. But I guess one of the claims to fame of the cecum is that attaching off of it is what's known as the appendix, also known as the vermiform appendix. It's important to note that this structure is found in the, or often found in the right lower quadrant of the abdomen, and this is also where often the pain of appendicitis presents. The reason this is that you get inflammation of the appendix, and enlargement, occasionally enlargement of the appendix, and then it touches the parietal peritoneum of the abdominal wall at approximately McBurney's point, as you'll learn in physical exam, and this presents as a direct pain as opposed to a referred pain. It's also worth noting that the psoas muscle lies just posterior to these structures. I'm not sure if that's the case in the model, but I'll pull it up here and check. Yeah, so as you can see, the psoas muscle lies just posterior to the cecum. This is a lateral view, sorry. If I rotate back anterior, psoas highlighted here. Just anterior, or posterior, my apologies, to the cecum and the appendix. And so this is why the psoas sign, another sign that you can elicit on physical exam when investigating appendicitis, gives you pain, because as the psoas muscle comes up and touches the inflamed appendix, you get pain. And a final note in regards to the appendix is that its position is highly variable, but it's believed that the most common position in Caucasians, at least, is its retrocecal. The last thing I wanted to talk about really quickly is the sigmoid colon. Not too much to say about it. Basically, it's attached to the posterior abdominal wall through the sigmoid mesentery, also known as the sigmoid mesocolon. It's found in the left lower quadrant, and this mesentery provides it with increased mobility as compared to the ascending and descending colon and rectum. Unfortunately, the mesentery isn't present in this model, but that's okay. You'll be able to see it in the cadaveric dissection. Alright, so essentially that caps off part 2 of GI Lab 4. I will see you for GI Lab 5.